We ready to go? Okay. Good afternoon, and welcome to the City Club of Eugene's December 5th, 2025 program, The State of Healthcare in Oregon, Part 3, If Not Now, When? My name is Thomas Hura. I serve as president of City Club, and I'm pleased to welcome you to another of the many forums we've held since 1990 in the name of our mission to build community vision through open inquiry. City Club is lucky to be a trusted, open, and independent voice for Eugene area community members to be heard. And as a lifelong Eugenian, I dare say the community is lucky to have the City Club in return and to hear from our program guests and questions from the audience, whether here in the beautiful Wow Hall, online, or over the radio. We believe these kinds of gatherings around critical community topics strengthen our understanding of one another and ultimately our ability to support the community building work in so many sectors of Eugene. In today's fractured information landscape, we want to be a space where you can participate in unearthing, disseminating, and sharing relevant information in conversation together. We would love for you to browse our past programs at cityclubofelugene.org or our YouTube or Facebook. Please consider becoming a member. Somebody just did today, which is great. If you'd like to support our rigorous volunteer work as Oregon's only city club that meets weekly. There are many ways to partner with us, and I'd like to thank our Diamond community sponsors. The University of Oregon has helped Oregonians question critically, think logically, reason effectively, communicate clearly, act creatively, and live ethically since 1876. Get more information at uoregon.edu. Lane Community College transforms lives through learning. LCC provides comprehensive, accessible, high-quality educational opportunities that promote student success. For more information, visit lanecc.edu. Thank you to the City of Eugene and to Lane County for their generous support as well. Summit Bank is our Sapphire sponsor. We're proud to do our banking at Summit, and we're grateful for the contributions of Summit's employees to our club and community. A quick reminder, please silence all cell phones in the hall. And with that, I proudly turn the mic over to Oregon's longtime state representative for House District 13, Nancy Nathanson.
Thank you very much. Hello, everybody, and this feels a bit like a reunion. The gang's back. The economics of healthcare in the United States is appalling. The current federal administration and Congress have been putting policies and budgets in place that pull the rug out from state and local budgets and kick patients to the curb. National pressures hit hard here in the Eugene-Springfield community. In 2023, Eugene lost its only hospital and emergency department. In 2024, I was here at City Club talking about a growing disruption in access to healthcare. There was already a shortage of providers, as there was nationally, but this was different. Doctors were leaving Oregon Medical Group. Some of their patients were making potentially dangerous decisions, like self-rationing because they didn't know when they'd get another prescription refill. Wellness checks and routine immunizations had been canceled. Over about 2 years, more than 30 doctors left OMG. Ambulances sometimes sit with their patients, waiting for space to open up in the emergency department. Urgent care clinics could help spread the load for people needing same-day care, but they're not filling that role yet, and they're not even registered or licensed. I'm trying to do something about that. The Cahoots Behavioral Crisis Service ended in Eugene, while another alternative response sort of took its place. Then OMG closed the OBGYN department as doctors departed OMG. Mackenzie Willamette Hospital announced its intention to build a standalone emergency department in West Eugene, but then the hospital leadership was abruptly replaced. Then Pacific Source announced it would no longer serve here as a CCO, a coordinated care organization, shifting about 90,000 patients to the much smaller Trillium CCO. All sorts of patients, physicians, and clinics will be impacted in some way. The disruption to healthcare has not abated, it has persisted and morphed. Primary care, emergency care, behavioral crisis, maternity. The state legislature does what it can around the edges in one state. We press on, trying to improve lives, improve the situation for our constituents in Oregon. In 2024, I worked with terrific local colleagues to draft and pass a bill to fund innovative approaches to provide right-sized care for people outside of an ambulance and an emergency department. The 2025 legislature passed several dozen bills, some of them regarding school nurses and physical therapists, and additional requirements for pharmacy benefit managers, dozens of bills related to healthcare alone. We removed medical debt from credit reports, required manufacturers to provide repair information and instructions for wheelchairs, and the big one, corporate practice of medicine, restricting individuals who are not licensed medical providers from owning or controlling medical practices. We put patients over profits, making sure doctors remain in charge of medical decisions. And you know how hard we worked for this one. We prohibited non-compete language in contracts with healthcare providers. Meanwhile, the consolidation in healthcare continues. Even the Government Accountability Office says, quote, there is also some evidence that physician consolidation involving private equity firms can lead to price increases for private insurance. Researchers at Brown University School of Public Health explain how consolidation is one of the main drivers of increased healthcare costs, and that private equity is associated with declines in quality of care in some settings and increasing churn or physician turnover. Our nation's approach to organizing and paying for healthcare, made worse by recent federal actions, has created chaos, anxiety, fear, and anger. Healthcare should not be treated like a commodity, like a car, a computer, or a box of cereal. It's healthcare. Oregon's landmark legislation to rein in the corporate practice of medicine has at its heart that healthcare professionals should be making decisions about patients' health, not out-of-state investors or AI algorithms. So here we are, struggling through each storm as it hits. I look forward to hearing more today about where we are now and what we can look forward to. Thank you.
That was awkward. Thank you, Representative Nathanson, and thank you all for taking the time in your day, busy day, to come here and join us. My name is Betsy Pownell. I'm coordinator of this program, and I'll be moderating it. Look around you. There are so many people here, so much interest in healthcare. Healthcare is arguably as important to us as the air we breathe. All of us have been affected or are going to be affected by the head-spinning changes in healthcare. If you feel like you're not being impacted by the cuts and rapid increase in cost, you are just one degree of separation away from someone who is. Maybe there's a different way of delivering healthcare that is low cost, equitable, and high quality. Here with me to discuss the healthcare crisis, where we are today, and what healthcare reform looks like in our state is Hayden Rickley, lawyer, health law and policy expert, Dr. Antonio German, family medicine physician and Vice President of Healthcare for All Oregon Governance Board, and Dr. Nick Jones, family medicine physician and founder of Clear Health Direct Primary Care. We're going to have a short discussion, and then we'll start taking audience questions without our typical traditional break. We have two guests that will ask the first two questions, and then we'll open it up to the general audience. There's a lot to cover. We won't get to it all, and we look forward to your questions. Okay, so to begin, Hayden, in a recent essay you wrote for Stat News, you suggested states, quote unquote, act boldly to mitigate the impact of H.R. 1 or the Big Beautiful Bill's cuts to Medicaid. How will H.R. 1 impact Oregonian adults and children who qualify for Medicaid? And what does acting boldly look like for the state of Oregon?
Thanks, Betsy, and it's good to be back. It's good to be with you all. You know, one central flaw of the U.S. healthcare system is how inequitably and inefficiently we allocate resources across the system. We spend $4.9 trillion in the U.S. healthcare system, nearly 20% of our economy. But again, the distribution of those resources is really critical to think about. Generally, the private health insurance system is actually overfunded. And we see this all through our premiums. 160 million Americans get their health insurance through their employer, and those costs continue to rise. Premiums, deductibles, out-of-pocket costs. The estimation this year is that covering a family of four will cost $35,000 for a family that gets their insurance through their employer through the private health insurance system. By contrast, the Medicaid program, which covers 70 million low-income and elderly Americans, is generally underfunded. And we see this in all sorts of ways, one of which being providers who see Medicaid patients are paid significantly less than providers who see privately insured patients. The cuts that are coming to the state in Medicaid, we're talking about roughly $1 trillion in cuts nationally over the next decade from Trump's tax cut bill. That's what we're referring to, the cuts that are coming to the state. Those can be thought of as essentially an exacerbation of this two-tiered system that we have. They're going to further under-resource the Medicaid program. And primarily the way this is going to happen is that the Trump tax cut bill made it more difficult for states to generate resources, to generate revenue to fund their Medicaid program. So the state is going to have less money to spend to cover people on Medicaid and to pay providers who see Medicaid patients. The consequences of this are amplified by the way that the Medicaid funding works. For every dollar that the state spends on Medicaid, so covering Medicaid, covering folks to be insured, paying providers, it actually gets matched by the federal government by more than $1. So the state chips in $1, and then the federal government spends $1 plus to help the state fund the program. And this is actually how the Trump administration is achieving the savings, quote unquote, to fund their tax cuts, is again making it more difficult for the state to fund their portion and therefore requiring less of the federal government to chip in their contribution. So if we think about the Oregon's healthcare system as a whole, the challenge is difficult, but it actually becomes quite obvious. And it's to try to move those resources in the system where we're overfunded in the private health insurance system to the Medicaid program. This will allow, if we can do this, this will allow the state to spend on Medicaid, which has become more difficult, and it will exploit this matching structure again. So if the state can spend that extra dollar on Medicaid, it can draw down funding from the federal government that it otherwise is going to lose. Whereas if we spend $1 as Oregon's healthcare system in the private health insurance system, we don't get that matching from the federal government. So this admittedly complicated structure here is really important to think about when we think about how to respond to Medicaid cuts. And that's what I mean when I talk about bold reform. This is going to require creative and ambitious legislation that at times can be politically difficult, but substantively in terms of what we need to do to try to sustain resources coming into the healthcare system and try to mitigate how many folks on Medicaid are going to lose their coverage, how many providers, how many hospital systems that see high proportions of Medicaid patients are going to have to close. The charge, again, is clear about trying to more equitably distribute the resources in Oregon's healthcare system towards the Medicaid program.
Thank you, Hayden. We have a lot to talk about. Next question, Dr. German. Dr. Bruce Goldberg, Special Advisor to Governor Tina Kotek and past Director of Oregon Health Authority and Care Oregon, was quoted as saying, "Our current healthcare system is structurally unjust." From your experience in rural healthcare and your involvement with Healthcare for All Oregon, can you expand on this statement? What does Dr. Goldberg mean by this?
Thanks, Betsy. Can you hear me on this? Yeah, okay, great. Well, thank you to Eugene City Club for the invitation here. I'm delighted to join you serving as Vice President of Healthcare for All Oregon, 501c3 nonprofit organization, advocating and educating all Oregonians about a clearer path forward for this. And I think what Dr. Goldberg is really illustrating, elevating the idea that in the patchwork framework we have of this healthcare system we put together, we have a multitude of different silos, and it's really put together as this fabric that's just threaded very thinly. And we're seeing how that is coming into the fray and basically falling apart in front of us. We have a system that we've been doing for 50 to 100 different years of putting programs together in health policy that we think are really delivering what we need, but they're really illustrating how it's faltering for all of us. So if we look at programs such as Medicaid, we look at Medicare, we look at different programs that we've been innovative in our state, we've done some remarkable stuff here in Oregon. We have things like Healthier Oregon program, which is the people might be aware of, Cover All People. We have the Bridge program. I served on the task force to help move that forward. And then we have a number of different smaller programs that we're seeing, but we're seeing actually with, even prior to HR 1, we're seeing some of those continue to fail for us. And I think that what he's illustrating is this conversation, is the social conversation, is I think about what the governor's goal is and what Oregon Health Authority has put in front of us for the 2030 goals of health equity for us as a state. And I think we need to look at the evidence. We need to look at the evidence of kind of what we've done from a health policy standpoint to say, are those delivering on what we want them to see? So the Commonwealth Fund does a study every couple of years to look to see how many people are delaying care or skipping the medications or procedures or the advice that their provider would recommend for them. In 2010, 34% of the United States participants said that they were skipping or delaying care. The most recent study in 2023 showed that actually that increased by 4% to 38% of individuals. When we look more locally at Oregon, we see more people skipping and delaying care even before HR 1. Hayden talked a little bit about the disparities in how inequitable our system is, and it comes down to we should prioritize and pay what we believe. So if we pay 60 cents on the dollar for Medicaid, for delivery of service, but we value more of commercial insurance that pays anywhere from $1.30 to $1.60 on care, and Medicare is somewhere around 80%. Well, I work at a fairly qualified health center. For years, I have treated uninsured. About 50% of my clinic is uninsured. The other majority has been Medicaid. And that's largely the marginalized communities that we have, and that's the Latino community. And I think that speaks to the value that we have, how unequitable, how unjust our system is. And then we finally need to look at these programs and say, well, are they doing what we want? And I think some things we were talking about, what am I hopeful? Is I think that actually the curtain is being pulled back for all of us. A lot of us in this room have employer-sponsored insurance. And I think we need to focus in on how inequitable that system and how it's failing us. We see nothing but our deductibles go up. We're seeing our premiums going up. We're seeing more people as far as when we look at the medical exchanges. We're going to talk about how that impact of ARPA today, how that has buoyed and subsidized care. But our system is only functional because we are subsidizing so much money into a system. But where is that money going? And we should look to where that is, right? And that's inefficiency, that's waste, that's to profit-driven motive. And I think we really need to look at these individual programs and say, is employer-sponsored insurance really working well for us anymore? And I would argue that it's not. You know, we mentioned that most employer-sponsored insurance is a Toyota Corolla every year. A family of 4 is buying a Toyota Corolla. But yet, when they go to actually try and use that care, they're seeing higher and higher deductibles because that's the only way we can make it affordable. And so I think that when we talk about this socially unjust, it's not only affecting those that are marginalized, but I think it's really affecting all of us in this room.
Thank you. Thank you very much, Dr. German. Dr. Jones, your turn. You have been quoted as saying that your medical practice and role as a direct primary care physician is a socialized healthcare experiment. Can you describe to us what direct primary care is, just in case there are audience members that don't know what it is? And how is it a socialized healthcare experience?
Okay, so I can definitely hear myself. Thanks, Betsy. And thank you, everybody, for coming and participating in the conversation on healthcare. I actually stole this from a young patient that came in. We do meet and greets in our office, kind of explain how things work. And it just clicked for them, hey, this sounds a whole lot like you're doing your own socialized medicine. For those of you that don't know, direct primary care, DPC, is a way at trying to achieve more health equity within a primary care space. It's where patients, regardless of whether or not they're insured, what type of insurance they have, they pay a low monthly fee directly to the doctor, and the doctor figures out how to navigate the healthcare system at the lowest affordable cost. So patients are paying directly for blood work that costs $2 to $3 a test, imaging like MRIs that can be done for $400 or $500, walk-in x-rays that can be done for $40. In the state of Oregon, we're even allowed to dispense medications, many of which are generic and can be purchased for 1 to 2 cents a pill. And when the patients get those types of savings and you're eliminating the middlemen, you don't have to worry because a blood test, a panel of tests, can run $20. A year's supply of diabetic or mental health or cholesterol medicine can run $10 or less for a year's supply. And so the direct primary care movement as a whole has done a really great job of figuring out what is the true cost to do these things in primary care and pass that cost and the savings on to the patients. As far as the socialized experiment goes, we serve a lot of patients that are uninsured. We serve patients that have Medicaid, Medicare, commercial insurance. Everybody pays the same. Now, where this gets really exciting is on the economic incentives. The incentives for the doctor are to get patients healthy, to be available to them when they need them and prevent them from having to go to the urgent care or the ER, because the doctor is getting paid the same flat low monthly rate whether the patient is in and out of the hospital or, ideally, doing well and reaching their health-related goals, as opposed to the traditional system, which is either done through fee-for-service. The more often you come in, the sicker you are, the more frequently we see you, the more we make per visit, or this value-based care model, which is really a way that insurance companies are collecting more federal taxpayer dollars to cover their insured patients because the doctors are wasting their time on the computer, checking all of the boxes, finding diagnoses, and even sending nurses out to patients' home to collect diagnoses. So they can in turn go to Medicare and say, hey, we need more money, these patients are sicker, look at how sick they are on this paper. Really perverse incentives the way things currently are. But if we can eliminate all of that and set up something where it is a flat, transparent monthly rate and empower patients to understand what services are included, you have this beautiful mixture of the socialized healthcare model where everybody pays their same and gets their same services, and you have free market economics at work where patients know what things cost and they see the value and are able to make decisions around where to take their care. I'm clearly very passionate about it, and I'm excited to talk about how we can both be innovative at a state level and think about how to best use healthcare dollars and take the lessons that have been learned from doctors doing direct primary care for the last 3 decades and seeing how we can extend healthcare access to as many people as possible.
Thank you, Dr. Jones. Okay, we have a lot of directions to go. I would like to focus on what will happen. What could the end of the subsidies and increase in insurance premiums be a breaking point for the U.S.? What do you all see in your specific, interests? What changes are you seeing? What hope do you have? What's happening, guys? Go ahead. Whoever wants to go first.
Sure. So there's a lot of moving pieces when we talk about state healthcare reform and what's going on at the federal level. The big changes at the federal level we were just discussing, huge reductions to financing the Medicaid program, which, as I mentioned, covers about 70 million Americans. That's slightly different than the Affordable Care Act exchanges, which have been the subject of the most recent government shutdown and the way those are financed. So 160 million Americans get their health insurance through employer-sponsored insurance, through their employers we were just talking about. You have another roughly 70 million who are get their insurance through Medicare, and then Medicaid, as we mentioned, about another 70 million. Then the Affordable Care Act was essentially meant to address the rest of the population, roughly 50 million Americans prior to 2010, that just didn't have health insurance and would have to go, if they wanted to purchase it, to what's known as the individual health insurance market, just go buy private insurance rather than get it through Medicare or Medicaid or their employer. What the ACA did was essentially subsidize folks in doing this and reduce the uninsured rate by about 20 or 30 million by providing subsidies to individuals who can essentially go buy private insurance. And these subsidies were enhanced in 2021 as part of the Biden administration and really helped to actually doubled the number of folks who were insured on these, what are called these ACA exchanges or marketplaces. And part of the Trump tax cuts was not only slashing Medicaid, but also slashing these subsidies. So this is estimated that to cause another, roughly 5 to 10 million people to lose insurance because the government's no longer going to be subsidizing the purchase of this private insurance. And so, again, this is part of the larger theme of slashing federal funding. And we can think about this similarly to cuts to Medicaid. You're going to have a lot of folks who are lower income but not eligible to qualify for Medicaid. We're talking specifically, to be wonky here, we're talking about folks who earn 138% of the poverty line to up to 400% of the poverty line, and then these subsidies actually go a bit higher based on these 2021 changes. So what we're talking about here is, again, at a high level, cuts to help lower income folks get insured either through Medicaid or through these ACA exchanges, and that's going to result in much of what we've discussed here. Fewer people are insured, they're going to show up to see providers. Providers aren't going to get paid, so more uncompensated care. More folks who are simply foregoing health care because they don't have health insurance. The basic story we've been fighting over for decades here is this question of whether everybody should be insured. We've certainly taken a step backwards in that mission at the federal level in the second Trump administration through, again, these major cuts to both Medicaid and to the ACA exchanges.
Yeah, I'll just add on a few numbers with that to make that a little more direct for people. With the Medicaid cuts, we're looking at 10 million people that are going to lose health insurance with the HR 1 changes. With the ARPA, depending on what happens on December 31st, if something proceeds forward, we're looking, as mentioned, close to 5 million people that lose health insurance across the country. Locally, that's going to be about 200,000 lives here for the Medicaid cuts. And then those that do get that subsidization through the Affordable Care Act medical exchanges, that could be close to about 35,000 lives that are going to be off insurance. That does not equate also to what people are really going to see when they're signing up. People are already starting to do that. They're evaluating their programs and they're looking and going to a health insurance broker, or they're looking online to see what their premiums are going to be. Most often what people don't realize, as I mentioned, about the way that we are making healthcare affordable is just increase the deductible. And then it becomes an insurance product that, what worth does it have if the average, so there's a couple of different tiers, and now we're getting into some wonkiness of different levels of different affordable care. But if you look at a silver plan, most of those are going to be $5,000 deductible plans, about 50% of them. The bronze plan, which we're probably going to see people move more towards a less robust benefits package because it's not affordable to have a premium when the majority of them are going to go up by 117%. Now, those that are 400% of the federal poverty level, they're going to lose all subsidization. And some of those figures are astronomical. Some people are seeing upwards of $1,200 more per month for a premium from some insurance brokers that I've spoken with. So that deductible for a bronze plan is upwards of $7,500. Then you can ask yourself, well, why do I even have insurance? And what that comes down to is that's somebody that's going to come into my clinic, and they're going to be uninsured again. And they're going to also, as I mentioned before, is are we creating, so what is insurance? It's financial security, right? And I think for all of us in this room to say, is what we're putting in play now working for all of us? And now I mentioned that, we used to talk about uninsured, we used to talk about the poor with Medicaid, but it really is impacting all of us with employer-sponsored insurance as well, and we're starting to feel that more. Is that financial security, 1 in 4 of us in this room will be uninsured on average. We will lose a job, we will shift, things come up, we have to move, right? That's a space where 25% of people are going to be uninsured at some point. And that could be when you're in a car accident, you have a heart attack. People like to think of health insurance as something that you have to use as a choice. I would argue most people that are accessing most of the health care, it's not necessarily a choice. It's out of necessity, right? We put in place 1986 the EMTAL law, which is an Emergency Treatment and Labor Act. And we as a society said, hey, we wouldn't kick somebody aside of the curb if you come in and you're injured. If you get a significant injury, we need to stabilize and take care of you. We also, as a state, in 2021, put forward the Hope Amendment. We said that we have principles and values that we want all of us in this state to have affordable access to health care. We need to be able to get the care we need when we need it. And what I think that a lot of this is taking place, back to the original question, is I think that we're getting to a point where people are starting to reconcile that this system, the way we continue to do this, if we keep adding this piecemeal system and we're expecting a different result, well, we need to rethink that. We really need to think that. We need to put front and center what we really want. We want everybody to have universal health care. That's why we put all these different systems. You know, we put Medicaid in place, we put Medicare, then I mentioned a couple of different programs we keep doing. But those, in honesty, I think really are failing us. And so, you know, what I'm really hopeful is I think this point is that over the last 5-6 years, the state of Oregon has been very innovative. It was saying, hey, let's take a different direction. Let's look at how we would get universal health care and fund that in an equitable fashion. And so that's a Universal Health Care Governance Board. And I think they're doing some really dynamite work that came on the heels of the Task Force for Universal Health Care that started the work in 2019. There are a couple of members in this room that are serving on those committees. I serve on the Plan, Design, and Eligibility Committee for that. And you know, there is no perfect healthcare system, but when you have it based off the values and principles you want, making sure that it's comprehensive, that it's high quality, that everybody has it, that it's portable, then I think we'll get there. A lot of health policy doesn't make sense, but this is a policy that does make sense. It's a politics issue, and it's about a movement of people saying, hey, we're tired of this, it's not working anymore, let's go do that works.
Thank you.
Yeah, I have a couple of strong sentiments to share. One, I think it's worth noting that the leading cause of bankruptcy in America is medical debt, right? I think I saw something recently where it's 1 in 8 Americans have over $10,000 in medical debt. It's obscene. And when we're talking about these deductibles and insurance and all of that sort of stuff, let's be clear, you're effectively a cash pay patient until you've met that deductible before you start seeing any of the benefits, right? And I think I also want to provide some context for everybody that these insurance companies we've all heard of, be it United Healthcare, Cigna, Aetna, Blue Cross Blue Shield, whatever, they're posing as healthcare providers because they're doing a lot more than just offering that insurance policy. Your ability to get blood work, your ability to get imaging, your ability to see your primary care physician, oftentimes even which specialists you have the ability to see are all gate-kept by these organizations. Whereas when you need an oil change in your car, the auto shop isn't running your policy to figure that out. When you've got a leak in your home, you're not turning to your homeowner's policy, right? The point of insurance is to protect you from financial ruin, right? But because they're getting in the business of healthcare delivery and they're owning pharmacies and doctors' offices and hospitals and trying to vertically integrate and control healthcare, they're able to scrape away margins everywhere from requesting a quote from your broker, who may be independent, but still making a commission and effectively an employee of all the insurance companies, to these artificially inflated prices on your labs, on your imaging, on your specialist visits, even co-pays for your doctor's offices, right? And so there's that perverse incentive for these companies that are by and large publicly traded, right? They have a fiduciary duty to their shareholders because they're on the stock market, and they care about quarterly profits. They don't care about getting you the care that you need that can prevent the heart attack that's 2 or 3 years from now, because you may be on some other insurance plan by that point. It may not affect their bottom line. The bottom line that they care about is quarterly. And that is where it's financially just at odds with what the patient-doctor relationship should be. And I think the other thing that we should mention is not all doom and gloom. What are our options, right? As a primary care physician that left a well-paying job and had to start his own practice, I'm uninsured, right, as a physician. When my wife continued to work and we looked at what would it take to get COBRA insurance? Anybody here that has ever seen one of those quotes straight into the recycling bin, right? It was like $850 a month for me, who has seen a doctor twice in his adult life, takes no medications, and knows how to take care of himself. $850 a month for effectively that sense of financial security that I could sleep at night, right? What about joining my wife? We talked about employer-sponsored plans. $650 to join my wife's plan when I had no income, right? I just started a new practice. How was I able to do that? There are these non-insurance catastrophic safety net plans that people can join. They can discriminate against pre-existing conditions. They're called health sharing cooperatives. Now, each and every one of them is going to be different. I probably shouldn't be endorsing any specifically through City Club. But it is one that I use because, there is one that I use because I do fun, dumb things like snowboard and mountain bike and rock climb, and I lift weights and do all these things where I could get injured, and I recognize that all it takes is one bad fall on the ski slopes, and I could be looking at an ambulance ride, an ER visit, surgery, rehab hospital, physical therapy, and all of these things that could rack up a six-figure bill that would sink me. So if you're one of these people that are falling between the cracks, that your insurance premiums are unachievable, please look into a health sharing cooperative and read the fine details and the fine print. Oftentimes it's the nuances around pre-existing conditions, but many of them don't include things like diabetes, high blood pressure, asthma, as long as you weren't hospitalized in the last year. But it could be an instrument that protects you from financial ruin. And for context, I pay $130 a month, and that is more in line with something that can protect me from catastrophe. Then switch over, and now the primary care needs, what I do in the office as a direct primary care physician, my patients can text me directly. They can call me after hours. They can see me same day, next day, get their prescriptions, their labs, their imaging, their specialists, all of that at cost, and we charge a low monthly rate. Less than that catastrophic insurance plan. I won't say my rate on here. But now you're talking about something in the range of $200 to $300 a month, something that's affordable for small businesses, employers that wish they could give benefits to their employees, but they can't because when they look at the marketplace, they see those same outrageous costs like we do when adding a spouse. I was raised an optimist, so I want to bring up some solutions and things that we can do about this. And when these insurance conglomerates are controlling every step of the insurance industry and the healthcare industry, they actually buy their own insurance. They just happen to own the companies that set those rates. Well, employers can actually go a self-funded route. And when an employer signs up with a direct primary care office, and that direct primary care office can deliver the savings on labs, imaging, prescriptions, referrals to specialists, and the employer can pay cash instead of the artificially inflated insurance prices, well, those employers can save anywhere from 40 to 60% year over year. And the unused funds at the end of those years that go towards it can help them self-insure at higher and higher rates, effectively lowering premiums year over year. And they can also write up the plan where unused funds can fund a patient's or an employee's health savings account, an HSA, which can grow tax-free in the stock market in the case that an employee does get something that needs to pay for their $8,000 deductible or whatever it may be. And if that patient stays healthy and lives a great lifestyle and doesn't need it, well, it's an excellent retirement vehicle that the employer can help sponsor for the patient. And lastly, some people even refer to these as community-funded plans because, and I'll insert a disclaimer here, I'm not an accountant, portions of the unused funds that were spent on healthcare can be tax-deductible donations to nonprofits. And you can even allow the employees to decide if they're going to collectively stay healthy and they're going to, save money at the end of the year, that's going to translate to improvements in their community. So there are solutions at fixing the employer-based healthcare system that we have if we agree to relegate insurance back down to what it was meant for in the first place.
Thank you. Tony, go ahead.
I just have a place to donate that to the nonprofit. Just kidding.
Thank you all for those answers. Clearly a lot of energy, passion, and hope. Okay, we're getting close to time for audience questions, so I just want to ask, so when we have an Oregon Universal Health Plan in place, how will direct primary care and universal health plan coexist? How would that
Oh,
work?
thank you. That's such a lovely question and something I think about all the time. I think the most equitable way to deliver direct primary care, or not direct primary care, and I want to be clear, I don't necessarily want direct primary care for all, but I think the best way to roll out primary care in a universal healthcare type system is through a food stamp-like benefit. Use it or lose it, resets every year, and now you're incentivizing patients to go out and get care. Let's say you have $2,000 on this debit card or $1,500 on a debit card, and you haven't had your mammogram. Well, you can get it. Or you haven't seen the doctor for your checkups or your prescriptions or anything like that. But everybody gets it. The doctors retain the autonomy to set their own prices. The imaging centers, the labs, we get free market economics, right? Because you can actually shop around and see what is the MRI cost at this imaging center versus that imaging center. What is my prescription cost at this local pharmacy versus this other pharmacy, right? And everybody's playing by the same rules, fighting for those dollars. And so you have this blend of free market economics with a universal safety net for everybody. And we all can acknowledge, just intuitively, that the savings for a universal healthcare system are going to come from primary care, preventative care, screening, and prevention of the truly expensive stuff. You can also allow this growing movement of independent doctors that have chosen to be paid on a flat, low monthly rate rather than paid per appointment, and empower the patients to choose. Do they want to go somewhere where they pay $300-400 for a visit, or do they want to go to a different doctor where it's $100 a month and they get unlimited visits and they can call and text? The pricing may vary, and maybe if you're young and healthy, you see the doctor once a year and you want some extra money in that food stamp benefit for lab testing or preventative care or other things, then great. Or maybe we decide that behavioral therapy is included with that. And we can subsidize that for those that can afford it, and we can make it sustainable. And then for those that can't afford it, well, they've got a really well-rounded plan that can give them the basics and the necessities to get them out of the emergency department, out of the hospital. And I'm not smart enough to figure out how to cover that with the universal healthcare system, but they could work in conjunction together.
Thank you, Dr. Jones. Very elucidated answer. Thank you. You guys have anything?
Go for it.
Sure. On this question of kind of patient shopping, Nick and I maybe see this one a little bit differently. There's been a push actually for decades, and we're seeing this now from the Trump administration, to essentially try to have patients be the shopper of their healthcare services. And to some degree, for certain services, maybe in certain elements of primary care, that can yield some benefits. And I certainly think that a lot of the folks who are leaving the corporate medical system, a lot of the physicians and other healthcare providers are doing so for understandable reasons. The health insurance system has gotten so bad that you see a lot of physicians who are just saying, I'm out, I'm going to go see patients direct pay. As Nick was talking about here, this requires a monthly payment for patients to pay for primary care. And it doesn't really address the cost problem in the U.S. healthcare system. Patients shopping for their healthcare services, again, might work in some limited context, but the things that really drive U.S. healthcare spending, hospitalizations, cancer drugs, visits to the emergency room, those aren't things that are particularly shoppable. There's long been, this gets to the very basic point that healthcare as a commodity or a service functions differently than the classic sort of like market ordering. So we have to ask this question about really whether we want to go down this path of basically just giving money to patients to buy their healthcare services and be these shoppers and try to decide, or whether we want a public insurance system like most other countries, other peer nations do, where prices aren't determined. The patient isn't sort of tasked with saying, do I want to go to this emergency room or that one, or do I want to get this cancer service or that one based on how much it costs? But we regulate the prices of these services at a national level. That's what every other healthcare system does to contain costs. So that's a slightly different way of going about kind of how we want to rationalize our system.
Thank you so much. Dr. German, I'm so sorry I'm going to have to cut you off. I want to leave enough time for audience questions. So can you bookmark it and save it? Because you're the universal health plan person. So anyway, we're going to open it up for questions. I'm going to bring the microphone down. We have two guests that will be asking questions. And okay, so let's see. They were invited. Okay. So can you go behind those two? Those are both good. Thank you so much. I'm sorry. I'm sure you've got a great question.
Hi. Can everyone hear me okay? Okay. My name is Esther Martel. I work for a local nonprofit called Shelter Care. I'm the team lead at their medical respite shelter up on Highway 99. We are not closing, I promise. There is some misinformation circulating. We are bigger and better than ever. So our program, we're a 19-bed facility. We serve individuals that are experiencing homelessness and require shelter while they recover from a medical event. So we provide housing and medical case management services and help connect people to medical supports that they need in the community. At this time, we are funded entirely through Medicaid. And one of our primary goals is to connect all of our program participants with a primary care doctor. So my question is, be it through like policy, advocacy, specific programs such as direct primary care, what is being done or what conversations are being had to protect low-income and unhoused persons to make sure that they have equitable access to health care and or access to shelter where they can receive that health care and not be languishing and dying on the streets?
Yeah, well, first of all, thank you for your work, and thank you so much for the services you provide. They're so necessary as far as just providing that for a very at-risk population. And I think this, again, is just illustrative of how we've marginalized some of the things that are really important care, and that's coordination of care and understanding that we're failing our community with that. We've decided that we're going to pay less for it because it's basically on Medicaid, right? We're not setting a strong priority for it. And this is why I think, us moving towards a universal healthcare system, because then we would even the playing field as far as how we're going to prioritize what that payment structure would be. I mentioned how we have silos of health insurance. For a lot of health insurance, it's not to their benefit to take care of one person for a short while because they don't know if they're going to be in a plan 6 months from now or a month from now, right? So for them to invest in all the upstream mechanisms that would really equate to better outcomes for this patient population, we forego those as a nation and as a state. We have put together programs to help with that, and we've put piecemeal some very good programs. Like we have the HRSN, which is a waiver on Medicaid to help support people when they're at risk for losing their homes to cover for housing for them. That's a very imperfect system because it's so piecemeal, right? That I think if we were able to have patient navigators and have more coordination of care, we'd facilitate somebody to really definitive care better.
I'm going to try and briefly answer at least why we need to spend more money and attention on Medicaid. Right? I did my training in Texas, and what I think a lot of people don't realize is when somebody is unfunded, whenever somebody doesn't have a means to pay for their services, it's effectively subsidized by county and tax, local and state taxes and hospital spending, But then for the hospital to stay afloat, they have to raise their prices on everybody else. And so whether or not we agree to fund a universal health care system, we can either choose, do we want to fund the preventative side and the primary care side, or do we want to refund a revolving door of the emergency department? Because we rightly agreed as a society with EMTALA in 1986 that we're not going to deny somebody life-saving care if they can't afford it. But yeah.
Thank you very much. Appreciate it.
Thanks for your question.
Next questioner.
My name is Joseph Washburn, and I work at Everyone Village. I'm the Director of Operations and Finance, and thankfully I just took off the programming and admin hats as well. Thank you, Dr. Jones, for your comments on what I perceive as providing dignity through agency and personal responsibility for potential universal health care options. I really appreciate that. And as we have this conversation about creating funding, whichever path it looks like, and maybe it's not an either or, it's a both and, just because there's funding for it doesn't mean it's actually accessible. And I'm just curious, as visionaries and architects of a better healthcare delivery system, what services and infrastructure would the panelists see being made available for a more effective primary care delivery system to be accessible? And by accessible, or successful rather, I specifically mean accessible and navigable.
I love that question. Thank you so much, Joseph. Yes to the yes and, right? I think primary care and expensive care are two totally different things, right? The hospitalizations, the chemo, the emergency surgeries, all of that, we need that funded through the state. The more lives that are covered, the safer it is. But accessibility and availability of primary care is paramount, right? And if we have this food stamp type benefit, the medical offices can invest in no longer needing or retraining their coders and their billers and the authorization departments of people trying to fight for the funding that they need to run the practice, and instead retrain them as care navigators and have more accessibility and availability for their patients. And so that's how I would like to see it.
Yeah, and I just might piggyback on, what are the resources and what are the skills we need, right? And so when you look at hospitals and you look at how much administrative waste is inside those things, or in my office as far as the billers and coders, I was going to comment just a little bit on primary care, is that, I think that a system like universal health care would promote. So when I went into practice about 15 years ago, I did not want to do billing. I don't want to do overhead. I want to do all of the everything goes into. In a system like this where the payment is simplified, I would love to go into direct primary care, right? And I think we'll see more people will go into those roles. So let's take roles that aren't bringing value added. I mean, they're great human beings doing that work. I love them in my office, right? But let's take them and let's put them into health navigation. Let's put them into traditional health work. Let's build up more nursing staff. We need to build up more primary care. Primary care doesn't pay. I don't know if anybody knows that in this room, right? Okay. So commercial insurance doesn't want to pay primary care as well, okay? So we need to restructure to say, hey, as a system, what are our values and what do we want, right? And we want more of the point of contact with Dr. Jones, with myself, right? And so if we can restructure that, then we won't, again, I keep beating a dead horse, those silos, because it's not built and constructed that way, but we should make it that way.
And if we want more primary care doctors, then we need to make it easier for them to deliver the care that they want to deliver. And have the financial incentive where they can make a good living and not just one extra year of training to double their income as a specialist. Because what the community needs are more primary care doctors, but we're a little biased.
And just to add, just the billing structures and everything that goes into it today, there's a lot of reason why people are not going into primary care, and a lot of people leaving primary care. And it really comes down to all the hoops and jumps that everybody has to do for the navigation of the billing and all the quality metrics and all the reporting and regulation that we have in that. And we need to simplify that.
Yeah, thank you. As all these marginalized communities are being left behind, I really am thankful that you're attempting to address these structural injustices, and we're not going to exacerbate them or perpetuate them as we do this, because I want those people to be able to catch up. So thank you so much.
Thank you, Joseph. Next.
I'm Jerry Smith. I've been a City Club member since 2003. you made a historical mistake, a really large one. Our government for years has spent most of its money protecting us from a foreign military action. And the Defense Department budget's been big forever. This new president,
Do you have a question?
you'll hear,
Are you asking a question?
this new president made a change. I don't know if you all know this, because it's so shocking. But he added a military to be used in the United States called ICE.
Excuse me.
ICE,
you-
please let me finish. ICE is twice the budget of our entire military. That's shocking. That's where the money went. It's twice the amount of Army, Navy, Air Force, and Marine. ICE is twice that. That is mind-bending. And I got to say, there's a certain German-American who budgeted it that way.
Excuse me, I'm so
and
sorry to
from
cut you
his-
off, but
his
we have other
famous-
questioners.
His famous
You make a
hero,
good point, but we need to-
Adolf Hitler. And that's
you.
why we're suffering. And
Thank
it's
you
going
very
to
much
get
for your
worse because
comments.
they've got all that money.
Thank you very much. I'm sorry to cut you off. We had some other questions. Thank you. Okay.
I've had this shirt for over 20 years. You guys are terrific, but my mind is still just boggled with all this Medicare, Medicaid, and health insurance. And I am a vet. I had terrific medical experience in the Army. I was a medic. I wondered at the time, why aren't we expanding our Army medical system, our military medical system to the rest of the world? Insurance companies aren't involved. And now that I'm a vet, I get really good care through the VA without any insurance companies in between. I get good service, and I think it's delivered a lot less expensively. Is there any thought about emulating either the medical military system of medical hospitals?
Thank you for your question. We're running really short on time. That's a great question. Do you mind if we turn it back to the speakers to
Oh,
answer?
okay.
Thank you very much.
Yeah.
Go ahead. And we only have 1 minute left, you guys.
Well, first, thank you so much for your service. My concern is just around capacity. I think the investment in our military and health expenses and how it's administrated, it is like a public system, and so there are some lessons to be learned from that.
Anybody else want to respond? Okay, you're the last questioner, and I'm so sorry we have to cut it off after you, so.
Sure. My name's Tom Peck. I live in Eugene. Nancy Nathanson laid out a great chronology of the decline of healthcare in Lane County. I'm very concerned that next year, January 1st, it's going to be incredibly rough for a lot of people. I think the elephant behind the curtain is that all of these hospitals and pretty much everybody who's providing health care is a corporate entity, and their bottom line is much more important than the patients. The largest company,
Do
United
you have a
Health,
question?
I'll be right, had a $14 billion profit last year. So my sense is, and this is the question, is that we put more, I think healthcare for all is is critical, but I think we need something more immediate, perhaps putting our energy into like Lane County Health and Human Services and expand their services for low-income people. So does anybody have any thoughts on
Good
that?
question.
Thanks.
Can you guys answer in like 1 or 2 words? Thank you for your question. It's a very good one. Our president is behind. Go ahead. One
Agree
word,
with the
2 words.
concern in Eugene and the degree to which the healthcare system here represents what we're seeing nationwide, which is sort of rampant corporatization, private equity investors, Wall Street publicly traded companies, large nonprofits that span the region, and forces this real question of whether those entities are extracting wealth out of our community and whether we want to try to move to a system where ownership is based more locally.
Yes. I think if you guys are anything like myself, we have some existential dread over what's going on. And I may be getting a little bit ahead of myself for the closing remarks. But the thing that's going to get us through all of this is a sense of community. And how our community responds to this is not going to be solved federally. I'm hoping it can be solved at the state level, but locally, even just helping your neighbors and just helping each other through moments of need can really get us a really long way. But that's a primary care doctor's perspective on fixing healthcare. So.
Well, this has been really spirited and meaningful, and I really appreciate it. But that's all the time we have for today. Please join me in thanking Hayden Rook Lee, Dr. Nicholas Jones, Dr. Antonio Gurman, and Representative Nancy Nathanson. This has been our December 5th, 2025 conversation at the City Club of Eugene. We'll be back here next week at Wow Hall on Friday, December 12th at noon. That program is called The Future of the Lane County Fairgrounds. It's sure to be a great forum, and we're looking forward to seeing you there. Thank you all. Have a great weekend. We'll see you next time at City Club.